Okay. Hello, everyone. Thank you for joining us. We're very, very pleased to have you here with us tonight. Um, my name's Erica. I am working for the World Health Organization, and I am one of the organizers of this series of webinars. Tonight, we are incredibly pleased and lucky to have two speech and language therapists with us to talk about something that we often have trouble as occupational therapists, physiotherapists, and other rehab professionals to manage communication and swallowing issues in emergencies and in particular in conflicts. Firstly, we have Mershan, who is a audiologist and speech and language therapist working at Massey University in Auckland, New Zealand, and he originally trained in South Africa. And next we have Helen. Helen is a speech and language therapist working at CBM Global in the Inclusion Advisory Group. So thank you very much. And over to our two presenters. Thank you.
Assalamu alaikum. So today we will talk about something that affects many people you encounter in emergency settings, communication difficulties and swallowing problems. And this presentation is designed for rehabilitation providers who may not have specialist training in speech and language therapy, but who will encounter patients with these needs.
So as Mershan just mentioned, we're going to be covering two areas today in one presentation, both communication and swallowing. And to do that, Mershan and I are going to split that up. So one of us will cover communication and the other will cover swallowing today. So when we're talking about both communication and swallowing, and we're talking about conflict settings, both of those things are two very, very common occurrences when people have suffered trauma, particularly head and neck trauma. But they're often really overlooked in the initial emergency response. They're not visible often, and there's a lot of other things going on that take priority. But we're going to talk today about why it is really critical to think carefully about communication and swallowing in these patients. So when we're thinking about communication, we're looking at people who have communication difficulties following, for example, traumatic brain injury. They could have significant burns. They could have something like a spinal cord injury. These things that can be quite common for you to see in these settings. And these patients may not be able to communicate even basic things after they suffered those kinds of traumas. So things like reporting pain, and reporting their symptoms to a medical professional can be really, really difficult. They can't necessarily participate in any decisions about their care or their rehabilitation, which can be, number one, very frustrating, and two, very frightening for somebody to not really understand why things are happening to them or being able to communicate what they feel about those things. And being able to express their emotional and their psychological needs. So often, finding themselves in a very distressing situation, but not being able to express themselves can cause a lot of distress, not just for them, but also for their family and the people around them who may not be able to understand what they're trying to communicate. And also giving informed consent for anything that they need to have as part of their care. If you're not sure about their level of understanding or that they're giving accurate responses when you're talking to them, then you can't be sure that they're giving true informed consent for their medical care, which obviously gives rise to clinical risks, but also lots of ethical risks as well. I'll pass on to Mershan to cover swallowing.
One of the things that surprises people when I tell them what I do as a speech therapist is that I work with swallowing. And most people look at me with a very quizzical look, thinking, well, what's that got to do with speech? Very different functions, but it is something that we would work with. And it's mainly because dysphagia or swallowing disability is one of the most dangerous complications following many types of trauma. As you can see in the slide, is a variety of different reasons for why we would be involved. So topmost would be the fact that we have to assess to see how someone is eating and drinking. specifically for recovery. And that, as you know, if you're working in emergencies, is critical to their survival. We're also particularly interested in looking at preventing aspiration-related pneumonia. So in other words, if things go down the wrong way, and instead of going into their food, to their esophagus, it may go into their airways. And so this is something that we'd be keen on monitoring and looking at preventing. Um, Airway safety and protection is critical to all of what underlies why we work with people who have swallowing disabilities or swallowing difficulties. Aspiration pneumonia is a huge cause of death in the acute phase following brain injuries and spinal cord injuries. So something definitely to be looking out for. And what I'm hoping to emphasize, and the key message that I'd like to leave you with this slide, is that these are not nice to have considerations. They're not things that we must perhaps look at. They are fundamental to patient safety and recovery. Helen?
Thank you. Could we get the next slide, please? Thanks. So when we're looking at the different types of conditions we might be considering in emergency settings and in conflict settings, we've just covered a few of the most common ones here, but a lot of the communication or swallowing risks we'll be talking about today could arise from many, many other causes as well, but you can still respond to the symptoms in the same way. So if we're thinking about traumatic brain injury, for example, a patient might present with language difficulties, so aphasia. It could be that they have difficulty understanding when people speak to them, or they could have difficulty using words either accurately or putting them together in a sentence in the right order. They could be jumbled or not make sense, or they could struggle to find the right words to express what they're trying to say. They could also have dysarthria or other speech sound difficulties where the way that they sound when they speak, they have the words that they want to say, but the way that they say them might be very unclear. It could be slurred, or it could be slow or very difficult to understand. And they might also have cognitive communication disorders that affect things like their attention, their memory, their executive function. So it could be that they can pay attention to small chunks of information, but not extensive amounts of information times before, or that they can't organize their communication very effectively. If I'm just going to go down the communication column, and then we'll pass over to talk about the same conditions, but how they affect swallowing as well. So with spinal cord injuries, you could have voice changes that affect the way people sound when they speak. So they've got the right words and the way that they're moving their mouth is accurate, but the way their voice sounds could change with different types of injury. It could be hoarse, it could be weak or breathy or croaky. They could be a ventilator dependent patient, which means that they can't communicate verbally at all for a period of time, which can obviously then be really distressing when a person is then able to communicate and then they come off a ventilator and maybe not be able to communicate comfortably at first. It can cause a lot of distress as well. When we're thinking about burns, particularly head and neck burns, then those burns can obviously cause a lot of pain. When somebody is trying to communicate as one thing, it can affect somebody's articulation, the way that they move the muscles for speech, meaning that they might not be able to express themselves clearly, or it's too painful to express themselves. And also, if they've been in a situation where they've acquired a burn, they may also have had smoke inhalation that can affect their larynx quite significantly as well. When it comes to blast injuries, hearing loss is one thing that you need to look out for. So somebody who was typically hearing before an event may then not be able to hear after and be very distressed at that. And also then it might be difficult for you to understand why they're not understanding you if you haven't tested for hearing loss. And also, if they've got a hearing loss and a traumatic brain injury at the same time, then not only can they not hear what you're saying to them, but they also may have difficulties expressing themselves as well. And then when it comes to polytrauma or critical illness, we've got things like intubation. So if somebody's intubated, then they can't communicate verbally at that point, but it can also cause laryngeal damage as well, particularly if it's been done rapidly in an emergency situation that can then affect a person's voice. With tracheostomy, then a person can't communicate when the cuff's inflated, but only if they have a speaking valve. And again, that can cause a lot of distress if somebody is very surprised they wake up and they can't communicate at all. And then we're looking at alternative forms of communication to be able to have them express themselves in a way that they feel that they can tell people what they need and what they want. They may also have things like delirium and fatigue. Things like medication particularly can affect people's functioning. They may only be able to communicate for short periods of time or take on information in very short bursts because of fatigue as well. So they're just a few conditions with common communication risks that you might come across, but also at the same time, those conditions also have swallowing risks as well. Motion.
And as Helen says, if you look through all those conditions, we have covered, as Helen has so nicely done, all of what might impact on a person's ability to be understood or to express themselves. With regards to swallowing, and one of the key things you might have heard Helen mention when she talked about traumatic brain injury or people with tracheostomies, for example, is that their voices might be it may be difficult for them to use their voices. And if you think about where their larynx is and how there's a shared pathway between the airway and the swallowing pathways, then this, of course, makes sense to understand that a swallowing risk is usually something that may co-occur with a person who has, for example, these common conditions that we've listed here. So with regards to swallowing across the first condition with traumatic brain injury, dysphagia, yes, is extremely common in anyone or usually people with moderate to severe traumatic brain injuries. And some of the difficulties, and we'll talk a little bit later about how to identify these, but one of the key things that you may identify at this point is what their voice quality sounds like and whether there's a wet and a gurgly voice. Again, like I mentioned, we will come back to this a bit later. With regards to spinal cord injury, especially those with anterior cervical surgeries, almost always have a dysphagia that lasts for up to 2 weeks because of the route of entry and because of the nature of the surgery, that they have to bypass the swallow mechanism in order to do the surgery. And of course, this impacts on the vagal nerve and the function of the nerve on how the larynx itself can adduct and sort of close off the airway. And as a result, you will end up with difficulty swallowing. With burns, as Helen also mentioned, specifically with inhalation burns, so this could be chemical and or smoke inhalations, they will cause damage to the lining of the larynx, to the oral cavity, and a whole range of other parts of the swallowing mechanism across the oral, pharyngeal, and or esophageal pathways, where swelling might occur, and it affects the ability to make not just make voice, but also to protect their airway adequately. With blast injuries, there's associated with all of the trauma that may assist along for what explains communication barriers, there may be other related issues impacting on swallowing. With polytrauma, even something like a small or short-term intubation may cause damage to the parts of the larynx as the intubation, especially if it's a traumatic intubation, occurs. And in short, I think one of the key things we'd like to emphasize in this slide is encountering people with these common conditions may almost always result in both communication and a swallowing risk. Next slide. The next slide, please.
Thanks. Okay, so back to me for communication. So
Mhm.
when we're thinking about trying to understand what a patient is able to understand themselves and the ways in which they're able to communicate clearly and effectively, there are some very simple things that you can do. So we're looking at low resource, very short time to get a really basic understanding of where you can go with a patient from there and what kind of information you can share, for example, with the other medical team or with family and carers around them as well, so that you can give them as much autonomy and independence as possible and reduce distress as soon as you can. So one of the most basic things you can do is a very quick kind of 5 minute simple screen. Starting off with, can they understand you as the most basic first step? Just before we go into that in a little bit more detail, thinking about the blast injury, particularly if they may have a hearing impairment from that or a hearing loss, then that's something we should try to rule out first. So thinking about, can they turn to noise? Do they react to noise before you do the comprehension screen? Because you might come to the conclusion that they can't understand when actually they can't hear. So that's an important one just to rule out first. But if you're confident that they can hear, like a voice level communication, then you can start with something simple, just to see if they understand basic kind of commands like close your eyes, for example, something they can physically manage as well. So, think about if they've got other injuries and things and what you could ask them to do that would be feasible for them. So you could then build it up a little bit more with complexity. So things like show me your right hand. So there's a little bit more to process. Obviously, only if they're able to do that physically, and start observing what they're able to then do in response to these simple commands. And you can build that up a little bit to two-step commands if you're confident in the first responses, until you get a sense of kind of what they're able to take on. When you do that, it's really important to, first of all, speak really clearly. If you're working with an interpreter, also explaining what you're doing and why it's really critical to translate directly as possible and to keep things short and simple. And you can also augment what you're saying by using gestures as well, or objects that are around you to help them to understand. After comprehension, after you've made your decision about whether they can understand at a basic level or a slightly more advanced level, you can do a screen for their expression. So can they speak? Can they communicate verbally? And we'll go into that in a little bit more detail in the next slide as well, but asking clear questions that they should know the answer to. Things like, what's your name? Do you know where you are? And then when you're listening to what they say, don't just listen to the words they say, but also the way that they say it. So, you're listening for voice quality there. Again, it can be a sign of dysphagia if you hear like this wet and gurgly voice that Mershan mentioned. Are they speaking clearly? Are we looking out for the dysarthria we mentioned in the previous slide? Are they able to find the words quickly? Are they able to access them when they need them? Or are they kind of grappling, trying to find the right words? And are they fluent? So that's, are they able to speak clearly and smoothly, or are they blocking when they try to get the sounds out, or are they repeating sounds? Are they repeating words as well? So that can give you an idea of whether they're having some difficulties with language, so the words that they're using, whether they're having difficulties with speech in the way and how clear they sound, or with fluency or voice as well. The next thing that's really, really important to ascertain is whether they can say yes or no reliably. And that's really, really critical, particularly for people with very limited communication, for them to be able to participate in choice making and decision making. And we will go into that in a bit more detail on the next slide, but basically asking questions that you know the answer to. So things like, is this your name? And give them the correct name, but also testing the opposite as well. So giving them a wrong name and saying, is this your name? And if they reply yes to both or no to both, then you know that yes or no is not consistent. So testing things against the correct answer and also the wrong answer, just to compare those answers. And if they can't speak at all after those steps 2 and 3, can they use different methods of communication? So can they do a yes/no response by nodding or shaking their head? Could they use gestures, or could they point to a piece of paper with some sort of form of yes/no on them in their own language? Are they able to write any responses? So thinking about what you have around you that's immediately accessible and that the patient's able to do physically as well. What's really important then is to document what you find, because if you do that assessment, but then in the next hour another professional comes in, and then it's really traumatic for the patient to have to go over these things time and time again. So important to document what you find so that you can share that with the other medical professionals, but also with the family as well, because they may be communicating with the person thinking that they understand everything they say and they don't, or that they don't understand why that person's not able to speak, and you can give them other alternatives to say, you could ask yes/no questions and they can answer in this way, which gives them a little bit more possibility for interaction. Could we get the next slide, please? Great, thank you. So on that, establishing the clear yes or no, and knowing whether their response is consistent or not, it's really, really important, because when you've got a yes or no, you're more likely to be able to assess things that are really clinically relevant. So things like assessing their pain accurately. They might, particularly if they've had a traumatic brain injury, the way they express their emotions might be affected, and they express things very differently to how they would typically do that. So being able to definitively say yes or no to assess their pain is important. Also to think about their preferences and their care needs. So being able to make a choice is a really, really powerful and dignified thing to be able to do. So being able to make even the most basic, simple choice can be really important for a person's recovery and psychological status, and also to have some control over their lives as well. Obviously, from an ethical perspective, getting informed consent as well. If you're confident that they are understanding spoken language and you're talking to them about particular procedures, knowing that they have a consistent yes or no response gives you a better understanding of whether their consent is reliable or not, which if they don't have a reliable yes or no, then you're looking at alternative decision-making process through a next of kin, for example. And then identifying new symptoms or deterioration as well. A lot, as you know, a lot of things that people experience, they're not necessarily something we can see. And if somebody can't communicate that their pain level has changed dramatically, or they're feeling something different and they can't report that change, then that can, number one, be a clinical risk, but number two, be very, very distressing for them as well. So we did just touch on some of the simple questions you can use there, but things like, is your name X, yes or no, and giving them the right name, and then the wrong name, just to see if they answer correctly for those things. But that's not quite, it's a good idea to do more than just the one type of question, just to make sure they're understanding different types of information as well. So are you in the hospital? Are you at home? Yes or no? Things like, do you know what year it is? Is it 2026? Is it 1990? Yes or no? And just see across multiple questions whether you get those consistent responses. So if they're saying yes to correct and incorrect answers, questions, then you know that their response is not reliable. So you wouldn't then go down the route of relying on the patient's response for clinical decision making, for example. You could look at them trying to express themselves using alternative methods, but again, if you don't feel that's reliable, then you could use that more for basic choice making over things like, what they would like to choose to eat or drink, for example, but not necessarily around more significant clinical decisions. Next slide, please. Okay, over to Mershon.
Okay, thank you. And so this, for me, is one of the most important slides because aspiration pneumonia is what is the key thing we're wanting to screen for when we're looking at people who may be at risk of a swallowing disorder. And it's important because it is a leading cause of preventable death following brain injury and spinal cord injury. So what do you do? How do you actually identify people who've got a swallowing disability or swallowing disorder? On the left-hand side of the slide, there's a list of several warning signs for people who may have a swallowing difficulty. Foremost, and I think this is an important point to come back to when Helen spoke earlier on about the people with voice issues, and I made reference to that again. Because of the larynx being the opening to the airway, if you can hear that someone's voice is wet or gurgly, then it's more likely that they have a risk toward an aspiration-related risk, that is. So that is one of the key signs, is listening to voice and whether it's wet or gurgly voice, especially after swallowing. Just one up before that, I've listed communication or coughing or choking during or after eating or drinking. Very obvious sign. And of course, these are things we would naturally respond to and go, oh, there's something wrong here. So we might be able to use coughing and choking as something that identifies a potential swallowing risk. However, not everyone will cough and choke all of the time. And the notion of people with silent aspiration, in other words, people who will have no obvious coughing response to material that's into their airway, is something that we need to be aware of. And this is typical of people who may have had neurological impairments usually. So, for example, people post-stroke. And I know that we're talking about trauma, for example, here, and not specifically focusing on things like stroke. However, people come into an emergency with histories of having other difficulties, including stroke. And so one of the things to be aware of is when we're listening out for coughing and choking, it is not the only sign that will identify a person who's at risk, especially if they are not able to cough and choke to cough adequately. The third sign on this list, with food or liquid coming out of their noses, refers to nasal regurgitation. And this typically tells us a little bit about what's happening with their soft palate and how well that muscle is working to close off the nose from the oral cavity. Nasal or velopharyngeal competence is what we would refer to that as usually. And if that is not working adequately, then you may have foods, liquids, especially coming through their nose. So that might be another sign to look out for. Drooling or inability to manage saliva is another obvious sign to see, especially if people are not eating. So in between meals, or if they are nil by mouth, then this is an obvious sign to look out for and identify as a potential problem to do with the way they are managing their oral part, just their ability to manage things orally. A key thing to note is whether they have either some kind of avoidance or refusal to eat or drink. And this is often something that I know in all of our basic training, we got to listen to what the patient is telling you. And this is their way of messaging to you that things are not right. And so they may avoid eating or drinking or just refuse it. There's also, and this is something that, of course, would be notable only over time, but it's unexplained weight loss or dehydration, which links, of course, directly to someone's ability to manage their nutrition and hydration through eating and drinking. And a key factor, which is, of course, as a consequence of having an aspiration risk or an aspiration-related pneumonia, is the fact that they have recurrent chest infections. So if a patient under your care keeps developing a pneumonia, then suspect aspiration. So those are some of the more common signs to look out for. There is a last one on that list, which looks at prolonged meal times. So someone who takes more than approximately 30 minutes to complete a plate of food may be at risk of having difficulties with their eating and drinking. What do you do in terms of managing this? So here's some key strategies at a very basic level to do. And while I'm talking about this, I think the header on the slide is a really important one to take note of. So while in most emergency contexts, you may not have access to a specialist or you may not have access to a dysphagia practitioner like a speech therapist working with swallowing, the idea is that eating and drinking is everyone's business, and we can actually look at how at least identifying what the basic abilities of a person is with regards to eating and drinking are. And so the bottom line is that screen, and once you've screened, then your basic primary care management would include what's listed in the green box on the right-hand side. So what do you do? Your basic default is if you suspect someone is experiencing a dysphagia, then you reset to a null by mouth status. It's often safer withholding oral intake than providing even alternative nutrition than to allow aspiration. Other key factors, which may be things to consider, would be positioning, posture, and what's listed on the slide. The most common ones would be, if it is all possible, is to get a person upright. And I don't mean perfect 90, 90, 90 here, but at least up to at about 30 degrees with the head and neck not extended or hyperflexed. So looking at how you might be able to manage someone in that position is probably a better position than lying flat. Gravity assist essentially in helping someone to manage the bolus, the foods that they're eating, and lying flat is not a good way to assist that process. Oral hygiene is one of the more common things to look out for, or the lack of oral hygiene when people who have difficulties eating and drinking are fed even something like water. Because if there's bacteria in the mouth or in the back of the throat, then if they have an aspiration risk, that's washed back into their toward the airway, and they end up with an aspiration-related pneumonitis. And so that's often people getting sicker quicker through the bacterial colonies that go and that wash bacteria into their airways. And so aspiration of colonized oral secretions we know will cause a pneumonia. So those are the key things to consider. And in summary, it's looking at considering null by mouth, managing a person's position and postural status, and then, of course, looking at key input around making sure they've got clean mouths. So that's oral hygiene. Next slide, please. Okay. Yeah, thank you. So this is just a quick review of stats for those of you who enjoy numbers. So if you look at the people that you might potentially work with in emergencies, like it says in the first block on the left-hand side, up to 50%, 1 in 2 people who have TBI will have dysphagia. So in emergency settings, especially where formal screening might not happen as a matter of routine, many people are fed without anyone actually even realizing that they can't swallow safely. So something to watch out for, of course, especially if people have not been screened for a swallowing disability. up to or between 30 and 50% of people who have been tracheostomized or are on tracheostomies have swallowing difficulties. In fact, the tracheostomy itself may disrupt the normal swallowing. And all you have to do is to think about the weight that a tracheostomy tube adds to the larynx. And because the larynx is so significant in helping us to swallow safely, that added weight reduces the elevation and anterior movement to the larynx, which allows us to swallow more safely. So that is a difficult thing for people to manage if they've got a tracheostomy, and therefore results in their increased risk of a dysphagia. I've mentioned this earlier on, and just to reiterate, to push the point about silent aspiration, it is a very dangerous form of aspiration because we can't on the outside pick it up. Just by looking at someone, we can't tell if they're aspirating, especially when they don't have adequate ability to cough or to respond to a material like water or saliva or even their own mucus, any of their body fluids that might be entering their airways. So the first thing that you might only pick up if someone is silently aspirating is a chest infection, and that could happen many days later. So if you're looking through understanding a bit more as a health practitioner working in emergency situations, these are some of the things to look through and be aware of as you work with people for how an aspiration pneumonia would develop. So for those people who will have neurological injuries, it weakens their swallow reflex, and this includes their sensory abilities, so which of course is the ability to cough, and their protective cough reflex may be reduced. Secondly, if you look at how they manage foods, liquids, and as I mentioned earlier on, even if they nil by mouth, they still have a risk of aspiration on their body fluids like saliva or mucus. So looking to see how that is managed by a person with a swallowing risk. I've mentioned earlier on and want to reinforce that bacteria from the mouth colonize the lung. So if someone's got poor oral hygiene, they are at an increased risk of aspiration-related pneumonias too. And of course, the infection develops once it enters their lungs, and you've got a pneumonia, which in someone who's already sick can be quite fatal. So this process of how someone develops aspiration-related pneumonias is something that we need to all be aware of when working with people who are at risk of this. A quick note around, especially people in working in low resource settings, is that this risk is considered to be even higher, specifically because we don't have any formal established methods to screen, or if they are untrained carers, or perhaps maybe people who are not in the right sorts of positions, so they're in suboptimal positions, and of course, like I mentioned, poor oral hygiene, and also where there's limited antibiotics to help someone. Next slide. And Helen.
Yep, so still looking at the common complications in this setting, but from a communication perspective. So communication breakdown, it can happen at lots of different levels and for many different reasons, particularly neurological reasons. But the reason for it happening is important to understand because it changes the way that you respond to it. So, for example, if a patient can't understand spoken or written words, it could be that they have a receptive aphasia or dysphasia, which means that they can hear you okay, but their brain can't decode the language that they're hearing. So they can't make sense of what they're hearing. It means that they can't follow instructions or they can't understand what's going on. But it also might be because they've got a visual deficit if they're looking at reading, written words. It might not be that they can't understand, but they just can't see what's in front of them. And if they didn't have a visual difficulty before, then it might not be something that the family or the carers are able to tell you has changed either. Or it could be a more broader cognitive deficit as well. Also, like Mershan mentioned earlier, and applies to all the things on this slide, is that people come in with pre-existing diagnoses as well. So you'll get people with learning difficulties that also then have a traumatic event as well. So thinking about and talking to the family or anybody that knows that person about their pre-existing history is also important. They might not be able to say words, so their understanding may be okay, but they're not able to express themselves, which we touched on before, but that it could be expressive aphasia. So they know what to say, but they can't find the words or they can't put them together in the right order to make sense. Or the words that they say might be all jumbled and kind of nonsense words as well. Or it could be that they do have the words and they know what they want to say, but the muscles of the mouth are either the nerves are not controlling the muscles well, or they have some sort of facial trauma that can cause a dysarthria or an articulation difficulty, which means what they say could be very, very difficult to understand. If they can't write words, again, that could be part of an expressive aphasia where they can't find the words that they want to write if they're not able to say that verbally. It could be due to a unilateral weakness, particularly on if they have a dominant hand. It could be they could have a neurological neglect, so they can only process information on one side of their body, or it could be a dyspraxia, so affecting their coordination. And the same, very similar things for gesture as well there. So they could have a weakness or a dyspraxia, or again, a cognitive impairment that means that they can't make the gestures that they want for expressing themselves clearly. Also, when we're thinking about voice that we've mentioned a few times as we go through, they might have a very clear voice but unclear speech, or they might have clear speech but an unclear voice. So those two things can be independent or they can co-occur as well. And that could be a dysarthria if they've got unclear speech, or some oral or facial trauma, or like we've mentioned a couple of times, a tracheostomy that's affecting their ability to express themselves clearly, even if they've got the words that they want to say. And then if they speak but the words make no sense, again, we're possibly looking there at an aphasia or some confusion or some delirium where what they say just doesn't make sense. The words are put together in the wrong order, or they've chosen the wrong vocabulary, and it doesn't make any sense. But also some people who also have a receptive aphasia may not be able to process that what they're saying doesn't make sense either. So they have no idea and they think that they're talking and everybody's understanding them. So it can be really, really frustrating when nobody's responding to what they think they're saying as well. Okay, next slide, please. So just focusing a little bit more on tracheostomy there. Tracheostomy diverts air away from the vocal cord. So a patient can't make any sound at all when the cuff's inflated, which can, if a person finds themselves in that situation unexpectedly, can be really, really distressing for a conscious patient. There are speaking valves that allow the air to pass through the larynx, but if they're not available, then you're in a situation where that person can't communicate verbally, and we're looking at alternative methods for them, such as gestures or body movements, or writing, or things like pointing or eye pointing. They might also try to mouth words silently, so they're trying to talk but they can't get the sound out. So you could also try to get kind of face to face with them so they know that you're paying attention and interacting with them, and try to read their lips. If their comprehension is good, you can maybe say to them, try to just say one word at a time, or try to make your mouth movements really clear, and then try to lip read what they're saying. But you can also then verify, or also use a communication board or a pen and paper to say, okay, I think you're saying this, is this correct? if they've got a good yes or no response, then you can kind of work through it in that way as well. Okay, and also they're on ventilator-dependent patients as well, then they're going to need different strategies for communication because verbal communication is not going to be an easy option. Okay, over to motion for swallowing.
Okay. One of the key things to note on the slide here is the fact that a patient with tracheostomy may have a cuff that's inflated. And there's a common a misconception that occurs with regards to the fact that when the cuff is inflated, there's an understanding that the patient cannot aspirate. And of course, this is false because we know that people who are on tracheostomies with inflated cuffs do actually experience aspiration-related pneumonias as well. And largely that's because, as I mentioned earlier on, their saliva and body fluids may bypass the cuff and enter the airway in any event. And so it doesn't eliminate the risk of aspiration-related pneumonias, but it does minimize the risk. The tracheostomy itself disrupts normal swallow mechanics, as I mentioned earlier on, because it creates a situation where the larynx and all of the muscles around that are tighter, so it tethers that particular part of the swallowing mechanism, and as a result, reduces the way the larynx elevates and moves forward, which is the movement that we require in order for an effective adequate swallow to occur, to allow for people to clear a bolus. So that's a key takeaway message on this slide with regards to tracheostomies. One of the things you might be expected to do is to assess the person's aspiration risk. And while it's not 100% with perfect positives or negatives in terms of looking at the sensitivity and specificity of this, the blue dye test, which is listed in the slide, is something that any clinician can do. And essentially what it means is either adding food dye to food or liquids and allowing for, if of course the person is eating or drinking, and then suctioning to see if there's any evidence of the blue dye that's entered the airway. That is not what I've described. It's not your classic blue dye test. The classic blue dye test is just simply putting a couple of drops of blue dye under the person's tongue and observing when suctioning if there's any evidence of the blue dye at the tracheostomy site. Next slide. We've covered a
Sorry.
fair amount of sorry. Sorry. Did you want to go?
Sorry, motion. Yeah, I just lost my mouse control to turn my audio back on for a second.
Okay.
Just when we're looking at specific conditions or complications to do with specific conditions, there's a kind of quick checklist here of something that you can bear in mind when you're looking at patients with a traumatic brain injury or a spinal cord injury or burn. So just a few things to keep in mind when you see a patient with these conditions. So for traumatic brain injury, might be looking at amnesia in that situation, but also like the way that they communicate, if they do have amnesia, might be unreliable and might change and be unpredictable as well. So they might be a little bit more able to be accurate and responsive at one time of day, for example, and a little bit less at another time of day, or not really remember what's happened or what you've told them in the past. So something to look out for with traumatic brain injury. Also with behavioral changes associated with brain injury as well. So they could be behaving in a way that's not typical for them, that could be quite distressing for both themselves and also the people around them as well, and affecting the way that they interact with people around them. They might also have fatigue, so they might not be able to engage in long communication interactions. So short and clear and to the point and prioritized is probably going to suit them much better so that they're able to take on the information and retain it much better and be able to respond more appropriately. Also, just something to look out for with traumatic brain injury is that if there's a sudden deterioration in communication, that could indicate that there's a raised intracranial pressure. So if their communication status changes really rapidly, it might be something that you want to take quite seriously and alert the medical team to investigate rapidly. When we're looking at spinal cord injury, any injury above C4 can affect the respiratory muscles. So that could then affect the voice. It could affect like stamina, vocal stamina, so how much somebody can say on a breath. It could affect the voice volume as well, and the voice quality. There's also a risk that if a patient can't express themselves very clearly, but they have an injury above T6, then they might be experiencing an autonomic dysreflexia, so an uncontrolled hypertension. But if they're not able to communicate that clearly, then that could be a real clinical risk because they're not able to report the symptoms as well. With burns, there's a lot of change that happens when somebody's got burns. So if you're looking at head and neck burns, the edema that can worsen over the sort of initial period, the 48 to 72 hours, can really have an effect on the way that somebody communicates, but also on their swallowing as well. So somebody who communicates in one way right after an injury might deteriorate for a period after that before it might improve again. But also, as the burns are changing, as they're healing, then you also might get some contractures, which might restrict things like jaw opening or the way that people can move the muscles for speech as well. So that can change over time. There's also any surgery that they might have to the area that can affect their communication. So they might be communicating in one particular way, but post-surgery, they might need to then use alternative methods or communicate in a different way. And also with burns as well, a significant thing is the pain that people would be experiencing depending on the severity of the burn. But like Mersham was saying before, the willingness to be able to eat or drink or the willingness to be able to speak related to pain might just be something that they're not able to cope with in the moment. So looking at alternative strategies as well. But just with all of those things, that things can change, the message being that things can change really quickly or over time. So these reassessments, like the communication screen on a regular basis, can be really essential. Mersham, do you want to say anything on that around swallowing before we move on?
No, I think we're fine. I'm going to come back to some of those points a bit later.
Okay.
Okay. We've got a few minutes left to cover the next slide, which is looking at rehabilitation challenges. And what I'd like, again, this is stuff, if you are working in a low resource context, will be very known to you. Just some highlights. The most important factor for me is about the language barrier. And at least when working with a person whose language is not the same as yours, to look at alternative resources. So looking at whether the patient can follow commands in their own language by having someone to work with them in the language that they are familiar with or are using. I'm not going to belabor the points that you see on the slide here, because like I said, these are things that are familiar to you, but they do create the context in which that we can consider when working in emergencies. Moving over to the next slide and looking at some of the ways in which we might want to adapt rehabilitation practices. I'm going to ask Helen to review some of the key points that are there, and we'll go from there.
Yep. Thanks, Mersham. Again, not to labor the points because we have covered a lot of this in what we've talked about so far, but some practical strategies that you can put into immediate use are things like simplifying your language, so short, simple, clear, slow, one thing at a time. Those yes/no systems that we talked about establishing earlier, and the multiple channels, so gestures, writing, pointing, eye movements, anything that's available to the patient that means that they can get their message across. And also things like simple communication boards where you can draw relevant pictures or write words or use an alphabet board so that people who are able to understand the information on there and make a reliable indication with a finger or an eye pointing, for example, can then also access those alternative forms of communication. Next slide, please. So just an example of that, on this next slide there's a pain scale, for example, where people could point to show their level of pain if they're not able to verbalize that. And next to that, a basic example of a basic needs board with just a small number of priority things like water, food, toilet, medication, family, help. And the key there is to keep it simple and prioritized, because overwhelm of like 50 different messages is going to be more distressing than being able to communicate your priority needs really quickly. So just a message that these don't have to be like professional, like fancy printed items, but if they're just clear and accessible, and if you can pop them in a plastic wallet to keep them clean and dry for use, reuse, then they can be really, really essential communication tools for people. Next slide, please. Over to you, Mershin.
On this, thank you. On this slide, I'm going to ask you to focus on positioning, diet modification, the way we feed people, and also looking at oral hygiene as some of the key things that all health practitioners in emergencies can focus on. There's a lot of detail, obviously, that's not on these slides. So there's a text that's referenced on the slide, and when you get a copy of these, please feel free to click on the link to access this free resource that has a lot more detail on how to do these. But for now, the important points to remember with regards to positioning is that it is one of the key factors that helps people stay safe. And it literally is using gravity as a friend and knowing that by manipulating someone's position, their body position, by doing things like chin tucking, so head and neck posture, to do that helps to protect the airway. And also other factors about when positioning is meant to be maintained. It is critical that after a meal, the person is kept upright. With regards to diet modification, I'm going to draw your attention to a useful resource, which is the International Dysphagia Diet Standardization Initiative, IDDSI, and there's a link to it on the slides and also in the resource that you have. And this carries useful information on how to modify foods that people eat or drink. Notably, something like water is the hardest thing for a lot of people who have difficulties with swallowing to actually swallow because it moves so quickly down toward the airway. Generally speaking, things like thick or mashed foods are easier to eat, but again, you'd have to look at how sticky these foods are. In emergency situations, thickening with foods like mashed potatoes, porridge, or even anything that's locally available that allows you to get the right level of thickness is going to be useful. So rather err on the side of a thicker liquid than something that's too thin, like water. Avoid mixed consistencies for foods, for example, like soup with bits of vegetables or meat in it and thin liquids, because they're often harder to swallow, given that the liquid flies toward the airway first before the actual solids do. With regards to how to feed a person with a dysphagia, one of the critical factors on this slide here is never feed anyone who's drowsy or sedated, for obvious reasons. And especially because when you consider that their key protective reflex, the cough, might actually be suppressed in that state. Ensure, insofar as it's possible, that there are minimal distractions during feeding and meal times. And then finally, with regards to oral hygiene, I think I've said this several times, so I'm going to push the last point around it. It really helps us to prevent pneumonias. if a person has a clean mouth. So something to focus on when looking after a person with a dysphagia or an aspiration risk. Next slide, please. Helen?
Uh, yeah, sorry, just go back one. Yeah, thank you. And just a quick word on mental health and psychosocial support, particularly around communication loss. We've touched on it in a few things we've said before about the frustration or, how frightening it can be to suddenly not be able to communicate, and maybe not understanding why you can't communicate as well. So just some tips there around unless you've established that somebody can't understand what you're saying through the screens that you've done, can treat them as if they're understanding, but keep things clear, keep things simple, but talk to them as an intelligent adult. You don't need to change your tone or the way that you talk to them as if they're more like a child, for example. Treat them like they're the adults that they are. Um, Things like talking over them or talking about them when they're in the room can be really distressing. So directing communication towards them, even if you need actually responses through the carers for more detail than you can get from the patient, actually talking to them can be really important to give them a sense of autonomy, to give them a sense of inclusion and what's happening around them and to themselves and involving them in decisions about their care, like I said earlier, even if it's at the most basic level, around a choice between two things, for example, can really help people to feel like they're part of what's happening in their lives. So there's a little bit more detail on that slide as well, but just bearing in mind that the mental health impact of communication loss can be really significant, very, very frightening, and anything that you can do for that person to increase their ability to communicate and to increase their chances of understanding what's happening around them can be really, really important. Okay, thank you. Next slide.
There are a few key takeaways that we'd like to share with you, 6 specifically. First, communication and swallowing problems affect patients across the range of conditions that we've listed. So blast injuries, spinal cord injuries, and critical illness. So always screen for both communication and swallowing disabilities. Helen?
Thank you. Yeah. Establishing that reliable yes, no, I think is a really, really key thing to take away. If you have that, you can start immediately with basic communication and even more significant things. If you're really sure that they have a consistent yes or no, it really opens a lot of doors for you as a clinician, but also for the person themselves as well. And the low resource communication tools that we just touched on then, the things like the hand-drawn resources or, the make by the bedside resources can make a huge difference. They might not seem like very much, but to a person who's just had communication loss and is suffering pain or, other trauma, it can make a real difference to how they're able to express themselves. And we didn't actually say this on the last slide, but communication disability doesn't actually equal intellectual disability. So treating people with dignity, respect, and like I said on the previous slide, that proceeding with the on the assumption that they can understand unless proven otherwise, is a way that that you can continue to give people the dignity that they deserve, even in these traumatic situations. Thanks.
And the last message on the slide, which is listed number 3, is left for the last comment, which is remember that aspiration pneumonia kills. And there are 3 simple strategies that you can use to prevent it: upright positioning, nil by mouth when in doubt, and adequate oral hygiene. Next slide. So even with these strategies, specialist input is essential in some situations. If it's available through the field hospital, telemedicine, or even through the organization that I represent, which is the International Association of Communication Sciences and Disorders, abbreviated confusingly to IALP, to its old name, has an expert roster of people to call on. So please do lean into these resources and refer to them as need be. There's a range of referral indicators that we've got listed. So with regards to when you might want to make the call for a referral, and it ranges through acknowledging that an active aspiration does require specialist assessment. Um, if you're working with a tracheostomy patient, then you do need some specialist input for how to manage their cough for things like speaking valve trials and also for assessing the ability to swallow safely. Thirdly, and I'm going to let Helen talk about the last 2 points here with regards to communication as well.
Yeah, so thanks,
Mhm.
Motion. In terms of the need for alternative or augmentative communication assessment, as a longer term, if somebody is going to have a permanent communication loss, then they might need then some more significant input around alternative or augmentative communication methods for them going into the future. So if that is available through services where the patient is, then referrals to those services would be essential for them to be able to use more significant alternative or augmentative communication. Yeah, I think the last one's
And
there about oral feeding, Motion. Oh, sorry,
yes,
there's one on
and
aphasia. I missed one, sorry. Yeah, and severe aphasia, if you do find a patient that's got really significant receptive or expressive language difficulties, that they're really struggling to understand what's going on around them or communicate verbally in a way that makes sense, then also if those services are available, then a referral would be recommended. Sorry,
mm,
back to you, Motion.
yeah, and I think the final reference or the important point to note is that there are resources to use. So please do reach out. So please do consider referring to resources via the IALP. And yeah, we hope that this is a useful pit stop for you to make when working with communication and swallowing in emergencies. And the last slide is the thank you slide. So thank you. And yeah, there's going to hand over to our facilitator for any questions and discussions.
Thanks, Mershon and Helen. That was absolutely great. So much useful information in there. Can I just ask one of you to maybe put the correct email address in the chat?
Mhm.
Helen, just quickly, I'm going to go back. There was just a question here. In use multiple channels, can you just clarify what you mean by speak and gesture simultaneously?
Yeah, sure. So if you're using verbal communication to talk to a patient, then you can augment or make give them an alternative to tune into as well. So as you're speaking, you can use gestures. So use your hands. You can also use facial expressions to help to give them another way of understanding the word that you're saying. So you might, for example, you might say, "Do you want a drink?" and make the gesture that looks like you're having a drink at the same time. So you give them as many opportunities as possible to understand the words that you're saying.
Great, thank you. Mershan, I'm going to come to you. This is a tricky one, and I think that it's okay if you don't have the perfect answer, but a lot of our participants are working in countries where access to things like feeding tubes and feeds is very, very limited, if not impossible. What sort of advice can you give to them about if they want to go, if the recommendation would be to go nil by mouth, how can they make some kind of oral intake safe? Or what would be your suggestions in the absence of kind of, so essentially trying to find that balance between safe swallow or safe feeding and avoiding aspiration pneumonia, but also meeting nutritional needs?
Very hard one to respond to, and something that
Sorry.
I've no, no, it's fine. But something that I faced myself and have had to make a decision. So often I return to what is the issue? Why do I determine that this person's not safe orally, and then address that problem? So, for example, if they're not safe on thin liquids, then we might have to make a decision to thicken liquids. If they're not safe on thick, sticky foods, we might have a look at how we make the boluses of the food itself cohesive. So balls of rice, for example, fortified with butter might be a better option than a porridge. Looking at things like thickening juices or thicker soups that are cooked and then cooled down to allow a person to swallow that more adequately. It's a really controversial response that I've given because a lot of people from other professions, for example, dietitians, nutritionists, may disagree with some of the suggestions for how you consider feeding. So do consider working with the whole team and looking at how, especially the modality of feeding.
Mm.
But I do agree that there's when you're in the situation, what do you do? And again, I'd like to point you to that book that I made reference to, which looks at addressing both specifically swallowing in underserved communities or underserved populations.
Thank you. And there's been
Mhm.
a couple of questions as well around, and I know you've both covered it, but just to reiterate that any kind of oral intake in someone that may have an impaired swallow, we want them sitting upright, want them awake, all of those things as well. Yeah.
Yeah.
Um,
So,
sorry, I'll let you. No, good.
okay.
Helen, coming to you, and I think this is probably relevant for some of our participants who are working in places where there is, really an extreme level of psychological trauma associated to the setting. So where there is a something like mutism could be present, how can rehabilitation professionals identify mutism as opposed to a different communication issue? And what would be your advice for for people working in those settings with people that they suspect may be experiencing mutism?
Yeah, it's a difficult one in these settings because often mutism is something that um, over a period of time, people may feel comfortable in particular situations or with particular people communicating, and in others not. So, in the initial stage, I'd say it's hard to make that diagnosis. But I think in a lot of these things, responding to the symptoms is the way to help the person initially. So getting bogged down in a diagnosis might take a long time and not be particularly helpful in that moment. But if somebody's not communicating verbally or, isn't comfortable, is fearful, has chosen not to do whatever the reason is for them not communicating verbally, could they communicate using those alternative formats? Can they write? Could they draw? Could they use gestures? Can they point to objects? So still giving them the opportunity to communicate at whatever level and through whatever means they feel comfortable with in that moment. And then as things progress and over a period of time, then it might be a decision for a referral to a professional speech and
Yeah.
language therapist if they're available, which we understand is not always the case, but responding in a way that gives people a method of communication that they're comfortable with in that moment is, I think, the best thing that you can do in an emergency situation with the resources that you have.
Yeah. So just trying lots of different options for communication and hope and in the hope that there might be something that's acceptable to that person.
If you do suspect it as
Yeah.
well, if there's psychological support, obviously go down that route as well,
Yeah.
if that's available. Yeah.
Yeah. Great. Thank you. A quick question for either one of you. Can you use fingers to cover the port of a tracheostomy to create voice?
Um, I can start the answer if that's okay. It's referred to as minimal occlusion, and yes, it can be used. but often you'd have to assess the overall ability of the person to breathe with
Yeah.
if their airway is occluded. So minimal means literally a second or two to establish whether they can produce voice or not. But if it's used as an ongoing method for voicing, then it means, and especially if there's obviously risk to the ability to adequately breathe, then you're not going to be using that as a primary method. And I'm sure Helen will reinforce that that alternative communication then becomes the key strategy in that voice.
Helen, did you want to add anything to that, or are you happy?
No, I think Roshan covered it there. Yeah,
Yeah.
the same advice as the previous question.
Mhm.
Lovely. I think this is a question that, again, I think you've covered well, but I think it's worth repeating. So, some patients tend to aspirate or choke on thin fluids like water, yet they're able to tolerate pureed consistencies. Why does this occur, and what interventions can be implemented to manage it? Just to recap, Mershon, on what you've said today. I think you've covered it well, but it bears repeating.
Sure. Essentially, water, like anything, is a thin liquid. And if you think about how water travels down a tube, like a straw, for example, it moves really quickly. But if you put something through like a thick milkshake or juice like mango juice through that same straw, it leaves a residue and it travels slowly. So that's exactly what's happening in your throat if you've got difficulties with your ability to adequately protect your airway in time. So the water goes so quickly that it bumps into the airway before it has a chance to close off the airway. And so that's really why it happens. It's the way the swallow mechanism responds to the movement of the liquid, especially the thin liquid, i.e. water. And so yes, that's why we would advise looking at a thicker liquid in that situation.
Yeah, thank you. Um, Coming to you, or to either of you, because it's about both, but I think there's a few sort of people asking questions about how do we make sure that dysphagia management in polytrauma patients who also have communication and cognitive impairments can be identified and prioritized. From a few of the questions, I'm getting a sense that some of the professionals online feel like it's hard to have those things prioritized in the face of multiple injuries and severe injuries as we see in conflicts. Um, any tips for identifying those issues and then as well as trying to advocate for them being a priority for these patients?
Motion, do you want to
Helen,
start on the swallowing or shall I start on
I'm
the
I'm happy for
communication?
you to go ahead and I'll pipe in with the swallowing components.
Yeah, I mean, I think just the quick yes no screen, for example, as a really basic 2-minute assessment, then can have, I think that the way to advocate for that is the clinical argument. If you can establish a reliable yes no, you can establish a person's pain level, they can make choices about their treatment, that you've got a better method of them expressing how they're feeling. Like, are you feeling hungry? Are you feeling thirsty? Are you feeling in pain? You can get that information out. So from a clinical perspective, it gives um, it gives you better clinical management. So I think the argument for a basic communication screen is that it gives you better clinical outcomes because you can make good decisions with the patient. And it can be literally as quick as 2 minutes for a
Mm,
yes no, if that's all you have. Um,
Mhm.
so yeah, just starting with that, and then obviously the more time you have or the more resources you have, then you can extend that beyond the yes no. But I'd start with that in really, really critical time limited situations. Um, that would quite nicely link to the dysphagia argument as
mm.
well, Mershan, I think.
And maybe if I can just get clarity around the question itself, around the dysphagia, is it about the screening per se?
I think it's if clinical signs such as cough are unreliable and there's communication and cognitive impairments, how can you identify dysphagia, ja, and implement a management strategy.
There are many quick bedside observation screening tools, one of which is a basic checklist which can be self-administered or clinician administered called the EAT 10, and that's freely available. And again, there's a link to that in that text I referred you to. So yes, you can do this. It also takes a few minutes to administer. And once you've ascertained the possibility of a swallowing issue, then of course management to look at what to do, what is possible with resources available around then follows. So like Helen, I reinforce strongly some kind of systematic screening, even if it's not, even if it's got poor sensitivity and specificity, which this tool does not, incidentally, it does. So it could be quite a useful tool to use to do a quick screen, which then enables you to think a little bit more about how to manage.
Mm.
Mhm.
All right, I'm going to create one last question for you both. I think we have covered in a lot of the other conditions around the importance of involving family and caregivers in um, implementing rehabilitation interventions as well as preventing complications. Can I ask both of you to just give us a, minute on what your priorities would be from a swallowing and communication perspective and how you can effectively provide education to family and caregivers on those issues for patients with impairments?
I can start, Helen. I think the first thing is just literally creating awareness. In 2011, when the World Report on Disability came out, there were absolutely no references to swallowing disabilities in that significant report, which tells you something about the level of awareness with regards to this in the disability population, and people with disabilities. And so one is I would actually ask these questions, engage people in discussions around it, make an awareness possible so that people can see and make the link between someone who's coughing or not, as the case may be, in relation to the eating and drinking. So firstly, absolutely create awareness around it. And there's nothing as powerful as that kind of that is an educational tool. Simply raising awareness, creating understanding. Um, Food is fundamental. It's a basic human right. And when people aren't able to access food and there's difficulty with um, having a meaningful engagement with food like they do with their families or their caregivers, then that comes with a whole range of other psychological and social concerns. So I think that's also something to be aware of. We've talked a
Mhm.
lot around the mechanical nature of swallowing and what happens for safety in emergency situations, which of course is a prime concern, but there's all the other things that could go wrong. And so looking at people being taken care of for the distress that they might have. So the mental health concerns around not being able to eat or drink is also something that's critical to manage. So I would focus on those two things, raising awareness of the actual impairment and then looking at how to take care of the person in this emergency.
Yeah,
Mhm.
always that. And I'm
Mhm.
glad you mentioned that, food is a human right, but it's also a really important part of the kind of fabric of family and community and culture. So thanks, Mershan. And Helen, last words from you. Thank you.
Yeah, thanks. Similar message really, for the family and for carers, understanding of, what's happened and why communication has been affected can be important, but at a simple level, like, they've hurt their head and it's affected the way that they can make the words that they need to or understand what's being said, but then concentrating on what they can do. So what can you do as a family? You can really help them to communicate by doing this thing and this thing and this thing, keeping it simple so that they can start to see that there is a way and there is a way through. And often if you need some resources like an alphabet board or things like that, families can kind of throw themselves into creating something that's helpful and give themselves a part in that positive experience for the patient as well. So I think basic awareness of what's happening without kind of heavy diagnostics going into it, but so they have an understanding of what's happened, particularly around things like expressive aphasia where people are using like jargon words or words that don't make sense, that can be really quite, I think, distressing for families. They don't understand what's going on. But then helping them communicate in other ways. I think that's something that families can get behind. And when they start to see some outcomes from that, then they're more likely to take that further and keep doing it with the patient as well.
Thank you so much. I think that's a great space to leave it on. Really, I think I'm correct that this is the first time we've had a really specific session on swallowing and communication interventions and assessments for, rehabilitation professionals working in emergencies. And I'm pretty sure it's not going to be the last. So thank you so much, Mershon and Helen. I know that it's probably very late slash early in the morning where both of you are. We really appreciate your time and your expertise. And I'm sure that the community of people that have joined us and will watch this presentation and will join me in thanking you. So thank you very much. Everyone participating, we will have our last session of this series on pain in rehabilitation, and that it will be next Monday, the 1st of June. So look out for the advertising for that on the World Physiotherapy page, as well as a lot of the other organizations. And the link has just been put in the chat, and that's the link to register for that session. Have a lovely evening, morning, day, sleep, and wherever you are. And we will see you all again soon. Thank you. Bye bye.
Thank you very much. Bye bye.
Thanks.
Thanks.